if you keep me near. Bri, this is Sam. Can you hear me? Copy.
We're gonna call the Cook County Health, Health and Hospital System Finance Committee to order. Will the secretary please take the roll?
Director Harrington is absent. Director Lowry,
Present.
Director Robinson,
Present.
and Chair Ryder.
Ryder's here.
You have a quorum. And, also for the record, we have Board Chair Garza remotely attending.
We have quorum. The, next regular meeting of the Finance Committee is scheduled for Thursday, April 10th at 10 a.m. Deb, is there anyone who is registered to provide in-person or virtual oral testimony?
We did not receive any registrations
Okay. And for either?
for either.
Okay. Let me just take a moment and ask if anyone is here to provide, public testimony, just to give them an opportunity. Anyone want to give, anyone here to provide public testimony? Charles, David, do you want to give testimony? Okay, all right. Thank you.
That was your chance to say Commissioner Lowry is pretty awesome.
Careful, Bill, I don't know if anybody's listening.
Here.
All right. First item on the agenda are the February 20th, 2026 Finance Committee meeting minutes. Just seems like yesterday. These were approved at the February board meeting, but are being presented for the committee's review and discussion if necessary. Are there any corrections that need to be made to the minutes? Any corrections? Any corrections? Hearing none, is there a motion to accept item 3A, the February 20th, 2026 Finance Committee meeting minutes?
So moved.
Is there a second?
Second.
Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? You guys have it. All right. We're now going to move to items under the Chief Procurement Officer. Charles Jones, our Chief Procurement Officer, is approaching the table. Charles?
Yes, sir.
Take it away.
All right. Good morning, Charles Jones, Chief Procurement Officer for Cook County Health. We have before you today 21 items. Of those 21, 20 require responsive letters from the Office of Contract Compliance. We have 14 back with 6 in progress. All right. That, Aaron Galena.
So request number 1, Health Plan Services, being presented by Eric Galiner, Chief Administrative Officer, Health Plan Services.
Good morning, directors. The first item before you is a one-year annual renewal of a contract that was awarded through an RFP process. Vendor is MHN-ACO. This is for care management services for the patients of federally qualified health centers that are a part of that ACO. Total impact is $43.6 million.
Any questions for Aaron? All right, thank you, Aaron. We're going to go to request number 2 through 5, being presented by Dr. Arnold Turner, Chief Hospital Executive, Provident Hospital, on behalf of Dr. Lawrence Smith, our Chief Medical Officer. Dr. Turner?
Good morning.
Morning.
Good morning. I have 4. The first one is a request to extend and increase the contract with Neurotech LLC for neurology, clinical neurophysiology, continuous EEG technician services. This was, the original contract was through an RFP. This contract is for remote continuous EEG monitoring and EEG technician services at Stroger. These services are required to support the neurosciences service line efforts to build continuous EEG program at Cook County Health. The contract period is for 24 months from 2/21/2026 through 2/20/28, and the amount not to exceed $2,790,000. The next one is a request to execute a contract with Richard Wolf Instruments Incorporated to services Guardian Gold Equipment Service Plan. This is a request for a pay-as-you-go service plan that covers vendors' equipment located both at Stroger and Providence. This is a service plan for urology scopes. This was secured through a GPO. The amount is not to exceed $900,000 for a 36-month period from April 1st, 2026 through March 31st, 2029. The next one is a request to execute a contract with Stryker Sales Corporation for the amount not to exceed $594,000 for ProCare service and support of arthroscopy and endoscopy equipment. This is a full service program for arthroscopy and endoscopy equipment currently in the fleet and on site within CCH. This is for a 36-month period from April 1st, 2026 through March 31st of 2029. And the last one I have is a request to execute contract here through GPO with Richard Wolf Medical Instruments Division. It's for scope equipment supplies. This is a request for the vendor to provide scope equipment supplies for the current fleet of scope equipment within CCH. These are disposable urology scopes for a 36-month period from April 1st, 2026 through March 31st, 2029. It's not to exceed an amount of $200,000.
Any questions for Dr. Turner? Hearing none, thank you, Dr. Turner. We're going to now move to request number 6 and 7, being presented by Shannon Andrews, our Chief Equity and Inclusion Officer.
Good morning. I have 2 items for you today. The first is a request to extend and increase a contract with Med1 Capital Funding. This is for maintenance services and leasing of Alaris infusion, epidural, and patient control anesthesia pumps. The request is for a dollar amount not to exceed $2,225,000, and it will take us through December of 2026. The next item is a request to extend and increase a contract for office supplies with ODP Business Solutions, formerly known as Office Depot. This is a request for an additional $565,000, and it will take us through November of 2026. And this contract provides office supplies across the system.
All right. Any questions on these 2 contracts? All right. Thank you, Shannon. We're now going to move to request number 8, being presented by Scott Spencer, our interim Chief Financial Officer.
Yes, good morning. So the first contract here is for Health Management Associates. It's an extend and increase contract for $461,626.89, and takes the contract through November 30th of 2026. And we use this vendor to prepare our Medicare and Medicaid cost reports.
Any questions for Scott on that one? If not, thank you. Are you doing the next one too?
Yeah.
Okay.
Yep.
Request number 9, finance and revenue cycle. Okay, go ahead.
Yep. So this is for Davis Bancorp. It's an increased contract for a fiscal impact not to exceed $30,000, taking the contract through December 31st of 2027. And this vendor is Armored Car Services and transports cash and checks from Stroger, Provident, and Blue Island to the bank.
All right. Thank you, Scott. Any questions? All right. We're going to move along to request number 10 through 12, being presented by Angela O'Banion, our Chief Information Officer.
Good morning.
Good morning.
The first request before you is for Vizient. It's a request to increase their contract. Vizient is our GPO. They are assisting us with the issuance of our electronic health record RFP, and they are also providing project management for that. whatever the selection is through the implementation.
Right.
CDW is part of our GPO group. This request is for most of the technology that we purchase in the hospital outside of the actual Microsoft license. This is for cables, this is for desktop computers, everything that you can pretty much think of that we would use, including some cloud services and licensing for that. So extend and increase. MCG is, and I'll give a bit more information on the sole source. MCG is a decision support tool. This is a company that pretty much started this market for care coordination. So you can think about it as physicians, nurses, care coordinators going to a website to ask specific questions related to, is this patient ready for transition to a different facility? Is this patient ready for to be admitted to another part of the unit? So specialized decision support services is sole source to MCG for an extend and increase because, as I said, they originated this market. Everybody has their software. They have thousands of employees, hundreds of nurses and doctors who create all these decision support technologies. And that's why this is a specialized product that helps the clinical team in the support of care of patients. And the final item is for Oracle Talent Management. You may have heard the term Taleo. This is a system that helps applicant tracking. It has allowed us to, as you know, improve our various metrics in HR. It's Oracle. The team is this extend and increase for a year, and the HR team, together with technology, does intend to issue a RFP for these types of HR services.
I have one question. When is the RFP anticipated?
I believe second quarter is what we have on that document. That if I could read it, it probably says that.
Thank you.
Second quarter this year, so sometime soon.
All right, that covers requests number 10 through 13. Any questions for Angela? Nope. You were good. We're now going to go to request number 14 being presented by Wynn Buren, our Chief Human Resources Officer.
All right, good morning. This is a request to extend and increase the contract to continue training Cook County Health employees on the basic understanding and operations of computer hardware and software. The vendor provides structured instructor-led training with course materials, handouts, and interactive sessions to ensure employees gain practical skills and knowledge. This is a request to extend and increase the contract in an amount of not to exceed $40,000 as needed for a 12-month period from 1/1/2026 through 12/31/2026.
Any questions for Wynn? Thank you. We're going to go to request number 15, Life Sciences, being presented by Dr. Mark Spronka, who is remote.
Good morning.
Morning.
Good morning. So this is an extend contract to MEDEX. MEDEX has been our staffing solution for the life sciences for a while, and we're proposing to extend it through 4/1/27. There's no fiscal impact to this request.
Any questions? Hearing none, thank you. We're going to move on to request number 16 through 18, being presented by Craig Williams, our Executive Chief Operating Officer.
Good morning.
Good morning.
First one I have is for Cintas Corporation.
We have some capital requests to talk to you about after the meeting. I'll talk to you about them.
Oh, good. Looking forward to that. It's an extended and increased contract for $1.2 million, 12-month contract period, 3/1/26 to 2/28/27. And they provide, through this contract, mops, cleaning supplies, floor mats, and carpet runner rentals throughout CCH. Legal Aid Chicago is an extended increased contract for $311,217, 12-month contract period 1/1/26 to 12/31/26. They provide legal services to our CCH population around obtaining public benefits, family law, housing, and they've really become an integral part of our interdisciplinary care coordination team. Their work sort of helps get patients at times to next level of care, or things that are preventing them from accessing care in the right way. We are requesting a sole source. We've been working with this company for a number of years and would like to continue that partnership. And the last one is Mid-American Elevator. It's an X2 contract for $4,869,729. 36-month contract, 4/1/26 to 3/31/29. And they will provide elevator maintenance repair services throughout our CCH locations, including both preventative and unscheduled maintenance. And this contract has 2 one-year renewals.
It is, we talked about elevators not too long ago. So are we running different manufacturers in the different buildings?
We are. This building has Kone, and everything else is Otis. And this is actually a new maintenance contract because we were unhappy with the service we were getting from the last contractor. So
It does seem, at least in this building, that we have elevators down all the time.
it's getting better. I have data on that.
Okay.
How many
elevators do we have in the system? How many buildings with elevators?
We have 8 in this building, and we have, I'm looking to my right. Yeah, 25 is at Stroger, and then at Provident, we have 2, 4, and then the elevator garages. So it's not it's a significant amount. And
They are elevators that get people from place to place.
really only up and down.
I feel like I encourage that sort of stuff, but
You opened it.
but yeah, and the elevators are all, I don't know why I'm taking us down this tangent, but the buildings were all built at significantly different time periods too, so.
Yeah, and that both, actually, we're just completing an elevator modernization at Provident, and we have an elevator modernization scheduled here at Stroger, which will create some disruption, but ultimately gets us that better reliability that we're looking for.
And are those, are those going to be Otis elevators, or are they,
The company that did the Provident was our last contractor, Anderson Elevator, and I think right now we're still at bid on the Stroger
Okay.
work.
all right,
Okay.
thank you.
Sure.
All right, request number 19 through 21, Stroger Hospital, being presented by Joseph Price, Executive Director of Ancillary Services.
Good morning, good morning.
Good morning. All right.
So this first request is with Quest Diagnostics. This is a request to extend and increase the contract for $3.6 million for a 12-month period. This contract was procured through the GPO process. And this is for the vendor to provide services for our laboratory department, which are currently not available here at the health system. This was the special pricing request. I want to note this has been honored to reduce the prenatal genetic testing by $664,000. Okay, the next request that we have here is for Trios Supports Pharmacy. This is a request to extend and increase the contract for $1 million for a 12-month period. This was procured through the RFQ process. This is a request where this vendor actually provides pharmacy transactions and manages the pharmacy connectivity between the pharmacy and other health plans. Okay. And this last one that we have here is with Beckman Coulter, another one for our laboratory department. This request is to extend and increase the contract for a 12-month period for $461,000. This vendor will provide instruments and reagents needed for the flow cytometry testing in our pathology department. This request is a sole source due to existing interface laboratory equipment, and switching vendors will incur an additional expense related to IT and laboratory reconfiguration.
Any questions? Thank you.
Thank you.
That brings us to the end of the request. Is there a motion to approve item 4A, contracts procurement items containing request numbers 1 through 21, subject to completion of review by contract compliance?
So moved.
Motion's been made and properly seconded. On the motion, Charles, is there anything else that we need to know about this before we move it?
No, sir.
Or before we pass it? All right. All those in favor signify by saying aye.
Aye.
Opposed? Guys have it.
Thank you.
Thank you. Well, hang on, so we don't have any emergency purchases, so we're gonna go right to items under the Chief Financial Officer being presented by Scott Spencer, our interim Chief Financial Officer. I believe we're starting with grant award related items.
Good morning again.
Morning.
Morning.
All right, so get myself organized here. Scott Spencer, interim CFO. Starting with the receive and file report for the month, we have 3 items. Executive sponsor for the first item is Dr. Kiran Joshi. And then the executive sponsor on the last 2 is Dr. Mark Spranka, and just for a total just over $4 million. Any questions on those?
Any questions on the grant award related items? If not, I would accept the motion to receive and file grant award related items.
So moved.
Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
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 Opposed? The ayes have it. I should probably note that Director Harrington joined the meeting. Director Harrington joined the meeting and has been participating since he arrived in a very complete and appreciated way. All right. We're now going to go to the January financials. Take it away, Scott.
All right. Good. Thank you, Chairman. So we have the financials through the first 2 months of the fiscal year. So as of January 31st, we are $31 million unfavorable to budget on an accrual basis. The county's preliminary cash report shows us just under $82 million favorable. The operational reality reflects pressure on both the revenue and expense sides that we are actively addressing. So starting with the revenue, net patient service revenue is 9.7% below budget, driven primarily by payer mix deterioration, where we saw a month-over-month increase in uncompensated care of 3.2%. And just to highlight a few things there, we've seen some volatility in the Maine pending approvals that have resulted in some write-offs. We've have seen the uncompensated care, particularly in the age range of 42 to 64, has increased roughly between 10 to 12 million on average since July of 2025. We also, of course, experienced the enhanced premium subsidies related to the ACA that expired on December 31st. So kind of a combination of things that continues to impact uncompensated care. On the county care side, membership running 3.4% above budget, nearly 387,000 members. And while this creates additional capitation revenue to the system, it also brings higher utilization and cost to the system. So next slide, please. Yes.
Yeah, I've never understood the difference between uncompensated care and charity care. I mean, there is a difference. Now, how do we distinguish from the two?
Yeah.
This is a very good question, one that I think people often miss on the subtleties.
Yeah. So yeah, uncompensated care would be the combination of charity and bad debt. So charity is the patient does not have the ability to pay, and bad debt would be the patient has the ability to pay but does not pay.
Yeah. Therefore, it'd be helpful at some point to see what the percentage is.
Okay. Yeah.
Yeah, we used to have a pie chart of that a long time ago. I think the thing to also keep in mind that the distinction, and Scott, correct me if I'm wrong, the distinction between bad debt and charity care that is not subjective. That is an objective number based on hard numbers, doesn't take into account everything else going on in that individual's life. It just gets categorized. They're above the income thresholds and things like that where they would have the ability to get care or be eligible to, be in like the managed care network, in a managed care network. So Scott's shaking his head.
Yeah,
I must
correct.
have nailed that.
Yep.
Yes. All right. So Scott, this is interesting, and I didn't know the difference either, so thank you for the question. I'm looking at that age range, and my thought is this is not necessarily a surprise to us, correct?
Right. Correct.
So then the next question becomes, if we can understand what they're coming in there for, which I'm sure that is recorded because you have to record it when they come in there, what they need help with and the bills and everything associated with the payments for it, or the lack thereof. So the question becomes, how can we get ahead of this? It appears to be a variable that's uncontrollable, but I question if it's uncontrollable. I wonder if you can direct it. Are there ways to, when they come in, to send them to maybe to a CHN clinic, or either try to persuade them? Because I know, at least I think we have those type of systems set up that if you need insurance or whatever the case may be when you come in, have we attempted to try to do that with this group? Because as we know, this number is going to increase. It's not going away.
So I'll take this one because this is a broader thing. So what we do, and this is part of the benefit of what happened during the adjustment to redeterminations and things like that during COVID, is we were able to get people signed up and keep more people on the rolls to get them insurance that would fall into that bad debt category. And now that has all lapsed, and you're recognizing this, it's now more of a threat. Also, looming cuts to the ACA also impacts this as well. The strategies that you're talking about are things that are deployed through a combination of our Chief Revenue Officer, Finance, which is over the Chief Revenue Officer, and Aaron's shop, all working together in ways that they can under the law, right? And I want to be careful of that because I know that there are distinctions, but and there's because you can be in a managed care network and get service here at Cook County. You can be in our managed care network and utilize the insurance at another hospital. Our mission as the hospital is, regardless of ability to pay, we take you. The idea around us starting a managed care network was to expand people's access to care and for our, our folks who come here, to have an option for them to do that. We do have, I believe, and Raul's hand is up, so I'll go to Raul here in a second, but I do believe that we have navigators on both sides of the fence that are looking to get people signed up and maintain them, that are through the hospital's function, and also through the managed care network.
So when a patient hits our system on the provider side, that happens as part of kind of the registration financial side of it. They run eligibility checks. They encourage them to get re-enrolled if they are eligible. And then if not, then it goes into the, the charity care versus potentially bad debt, right, kind of discussion. On the health plan side, county care is leading the pack in Illinois in terms of the retention. We talk about this in the managed care committee, but, they're 88 to 91, 92% in terms of their month-over-month retention rates. As people come up for redetermination. State average is 72, unfortunately, and another piece to that we have discussed is that our domestic spend is about 10% for county care, right? Meaning that people coming with county care coverage don't necessarily, we're working to fix this, right? But that has been kind of a historical trend, right? Where county care insured patients aren't necessarily coming to CCH. We're working to fix that, but if you extrapolate out those retention rates, we're seeing an outsized impact because we're getting patients from the other members from the other MCOs who are losing at a higher rate than county care is, right? So we're seeing more loss on the provider side when they come with Medicaid coverage from an MCO that has lower retention rates, right? People are losing faster in those others. Now, part of the Medicaid Impact Work Group that we've put together is to create a standardized playbook for the MCOs to really kind of model after what county care has done with their outsized retentions, and try to encourage the other MCOs to do that. We have, Aaron, what is it, 20 plus redetermination events every month? I mean, they're really focused on
help me
retaining.
understand why we're receiving, it's a discount for us, well, not a discount, but we're losing when it comes to other MCOs. That part I'm not making that connection.
So the state average's retention is 72%, meaning the other MCOs are not at the level that county care is. And when we have outsized experience from other MCOs, patients coming to us from the other MCOs, the trend is that they're losing more patients than county care is. So by keeping county care patients in, right, they're keeping more patients on the membership lists, meaning that we wouldn't see as much of an increase in the uninsured by having the other MCOs coming to us. We're seeing more uninsured patients coming because they're losing more patients.
So it's to our benefit to be a good partner in the community to the other MCOs, even though we have our own MCO, because the more, if they're not retaining and we're not converting them to our network, it would be the easier thing for an individual. We're not a company we're not Blue Cross or United Healthcare. It's to our benefit on the provider side if the other MCOs are retaining their membership. We would always like to have our network be bigger, but we're not going the approach as the leading public healthcare institution in the Midwest, if not the country, is to make sure that everyone's got coverage. So the more success that the other MCOs have on their retention rates and getting to where we're at helps us drive our ability to recoup on the provider side. And what I think would be probably the best way to tackle all this, and I don't think I want to do it all in one meeting, is for Scott to pull together folks from his team, which would include various people in revenue cycle, and also maybe on the hospital side, to walk us through sort of what Eric just did on not just how it operates when someone presents, but also the trends that we've seen, because we've even before, and I'm looking at Letty, because she was here when we started the managed care network and all the work we did to get the managed care network up and running, and then when we acquired other managed care networks, show the trend on being able to knock that down and also isolate the period of time where the redeterminations were automatic or whatever, suspended or however, where we didn't have to worry about it. And then I'll give you a view of the trajectory that we've been on. And then I think I'd want to do it not all at once. And I know that this is also a topic for the managed care committee, but I think looking at it through finance is if Scott can do that next month, let's say, the following month, Aaron, if you could give us a deep dive on what you guys have been up to and show us the trajectory. And Aaron's been, you know, Aaron's been in our managed care network longer than he's been the director of it, so he should be able to give us a good view of it. That way we're having a substantive thing, and then it's sort of all fronted, so we're not looking at it like, okay, how can we do better right now? Well, let's look at how we got here, and then see what else we can do, so that way we get the full picture.
Yeah, I'd like to offer up an observation, something that I've learned over the years. Even if people have insurance, regardless of what it is, most people don't get the routine screenings that they're supposed to do. They don't go in for their regular colonoscopies because they feel healthy and they're not seeing a doctor. They're just routine tests that people miss. And one of the things that I talked about some time ago is you can see, even in our managed care population, there's a significant drop after the age of 20 with people actually having visits, going to the doctor. And it begins to spike up around the age of around 50 or 60 because people have been in a state of disease, which could have been caught early, but it wasn't caught early because they didn't come in for routine screening. And because they didn't come in routine screening, now they're in an advanced stage of cancer, which is much more expensive to manage and much more difficult to treat. And so there still needs to be this emphasis on getting people to actually take care of the benefits when they're not sick. And that's why you see a lot of people in emergency rooms that really don't need to be in the emergency room, because that's how a lot of these things get detected, because now something is not working and they're in the emergency room. They find out they might have a small tumor over time. They might have had a heart attack that could have been prevented if somebody knew they had some kind of congenital defect, but they failed to go to the doctor, they failed to manage their blood pressure.
Just for reference, in terms of a cost perspective, when you look at something like colon cancer, right, it's a $2,500 colonoscopy versus, I think we may have talked about this before, but stage 4 cancer, surgery, inpatient admission, chemotherapy, all of that, you're increasing the cost to about $130,000, right? You guys have 2,500 versus 130.
Yeah. Okay, let me go back to one part that you said that caught my attention. It seems, and correct me if I'm wrong, because this is what I think I heard. There are people who are losing coverage with the other MTOs, and they're coming here for care. That's creating a problem for us. So they're eligible for coverage, so we're assuming.
Should be re-enrolling them.
Right. And so we don't have any opportunity to then slide them over to county care?
So we do, that's what we're.
Earlier when we were talking about the navigating, right, the navigators.
Yeah, so the patients have to select, right, when they re-enroll, but yeah.
They could select their, that's the difference between what we do on the provider side, also on the network side. We can advise them of their eligibility of who they could select. We're, you know, Aaron's operation is one of the choices. They could re-enroll with the MCO that they fell off of, or they could enroll with us. Obviously, the folks on the, you know, we have to, and again, there's a lot of rules around this, and if Ellie was here, she would probably have her hand like this, just waiting for the time to intervene. So I think the best thing to do is to probably have, hold the rest of this discussion until we get the presentation, and then we'll have all the right people.
Do you know if the rules are federal, state, or local?
Yes.
Which one? All three?
Well, no, I think state and federal rules around it. You know, a lot of it's going to be driven by federal rules. But there are contracts and legislation. So I don't want to speak out of turn because our chief legal officer isn't here, but but she has a lot of experience in this very thing. And last time we had a discussion, we kept it on the right side of it, but we were starting to, as you recall, she interjected to make sure that we continue to stay on the right side of the discussion.
And I'm assuming.
Oh, Ellie has her hand up. She's in the ether, Ellie. And then we got to go to Raul. Raul's waiting to talk.
Oh, go ahead.
Raul, let's go to Raul.
Yeah.
We'll go to Ellie.
Yeah. Well, I didn't know Ellie was on, but I was going to offer my limited legal opinion, which it's a CMS requirement that you can't self-deal. I think Ellie will confirm that. It would be a Stark violation if we were doing that. But regardless, she's the attorney, not me. Scott, I want to go back to you about a clarifying question. So I assume that most of the bad debt is coming from patients who are uninsured that have been determined to be ineligible for Medicaid, and therefore they've been determined to not qualify for Medicaid, and then that puts them on the hook for paying for the cost of care, which I would think an abundance of that bad debt would be coming from that population. Is that accurate?
Yeah, that's certainly a part of it.
Yeah, and it gets,
how big a part of it is it though?
It would be, well, just looking at our payer mix, it would be the majority of it, because there'd be a smaller portion coming from, maybe a patient with a commercial plan.
Right.
But yeah, it's going to be the
that has a contributing end of it. But so I appreciate the exercise that is being proposed to go through. But I think when we're talking about an abundance of the bad debt coming from an uninsured population who might suddenly find themselves uninsured, like we saw happen last July with the immigrant population, I don't know much more you can do about that in the planning, because it is a sensitive topic. I mean, as a practitioner, we have to deal with that as well, on how much pressure you want to put on collecting the bad debt from patients that don't have insurance. And although if they're uninsured, they're either going to be in the population that is part of the working poor that doesn't qualify for Medicaid, which is only going to exacerbate in the next 8 months, or we change our philosophy and put pressure on them. And I don't know that that's the will of the Cook County Health leadership or this board or Cook County commissioners. So I think the exercise will be valuable, but I think we also have to look at, where's the majority of this coming from and what, if anything, can be done. So just want to put that out there, but I'm glad you confirmed what I was thinking about the bad debt part of this conversation.
Yeah, and just to that, and then we'll go to Ellie, is that poverty is the legal definition of poverty that could be pointed to in statutes. Some does not necessarily track what people's actual experience is, because they're looking at incomes coming into a household, how that's spread out, what the eligibility is. It's also a number that is that I'm sure is when it's inserted and how it's come to be created is backed by someone's data, but everybody can disagree on that data and how it could be indexed and everything else. At the end of the day, with an affordability crisis, with everything else, and people and the gentrification of communities, especially in an area like this that has, in Chicago, that has still a lot of geographic racial segregation, and still a fair amount of economic segregation. The laws aren't written to capture all those people, and that's the group that ends up driving this number. Of course, I think there is, like I think Scott alluded to it, there are people who they have coverage, they have a copay, they have a $2,500 copay or whatever, and they're not paying their share of the provider bill to us, but that's not what drives this number. We will always be a hospital that takes people regardless of ability to pay, however that presents. Do you want to say something before I go to Ellie? It looked like you wanted to say
Well,
something.
I was just gonna add that, there's, this whole process requires cooperation from the patient, as well. So, the patient navigators can, do what they're doing to get, an application and get coverage for the patient. But, I think a lot of or not a lot, but to some degree, it's impacted by, the patient not cooperating in the sense of they're not providing the documentation that they need to. So I just wanted to throw that out there, that it's a cooperative effort.
So let me ask this question, because this is, Chairman, Garza actually.
Here's what I want to do. And I'm sorry to interrupt. I want to go to Ellie, and then I want to hold this discussion once we have our lawyers speak to the meeting where that's gonna be designed to do this, because I think we'll have everyone's questions will be more structured and informed based on the information that gets presented first. It may have the same questions, may not. Ellie?
Yeah, so I think, good discussion. A couple of things. I think first, in general, when we're talking about there's nuance between steering patients and between creating efficiencies, quality, safety efforts. Steerage is generally looked not as favorably from government agencies, whereas the second, things that move towards patient satisfaction, patient quality, patient safety efforts, those are generally approved. So there's some nuance there, and there are some ideas that I have that we can work with in the future and do so in a compliant manner. I did want to say, this is the type of sort of more in-depth managed care training that we could next have for our leadership and our board to attend, if that's something that you guys are interested in, and we can walk through what the boundaries are, both in how people qualify for things, but also in what can we do once we have a beneficiary, what can we offer them, how we can use things like clinically integrated networks and accountable care organizations and things like that. So I'd also offer that, if that's something that there's interest in, that we can certainly provide in the next couple of months.
Yeah, so that's exactly what I'm looking for in the presentation that I want to have, and the way I'm viewing it now is to have the presentation from the perspective of the hospital first, as a provider, and then maybe from the managed care network second, either in that same meeting, or if it makes sense to segregate that into a second conversation at the following finance committee meeting, and we make sure that we have enough time on the calendar, because I think it'd be helpful for everyone the committee to be in the room together versus doing 2x2s briefings, because I think that everyone hearing each other's thoughts would be helpful. And then Ellie, I definitely want to make sure that when we do this, that you're setting the parameters of the discussion, like you just did. So I would want to have you folded into both of those presentations.
Sounds great. Thank you.
All right, Scott, keep going.
All right. Okay, so let's see. So I think we're on the we want to go to the income statement there. Sorry, I kind of lost track here a little bit. So as we work through the income statement, again, the adjusted net patient service revenue short by the 9.72%. Revenues in total favorable by just under 7 million, so adding in the capitation. And then as we move through the expenses, a couple things to highlight there. While salaries, benefits, and overtime are in total favorable, we are going to be looking at the overtime and just making sure that that we're managing that and taking advantage of any opportunities there. We're continuing to work on reducing the reliance on agency as well. So continued efforts there. So total expenses are unfavorable by the 4.4%, which is driven mostly by the medical claims expense from the health plan. So in total, net loss of 30.4. So we can flip to the next slide, so we can see the breakdown between the healthcare side and the health plan. So you can see the net loss of the healthcare side at just under 2 million, and then the health plan coming in at a loss of just under 29. The next slide, the waterfall report, just as we have been continuing to highlight the favorable and unfavorable drivers. So the unfavorable drivers being the net patient service revenue that we just talked about, as well as the medical claims expense, and then the capitation revenue being favorable along with the salaries and benefits and purchase services. Next slide. So a couple things to highlight on the volumes. So short of budget at Stroger on the inpatient as far as discharges go and ER visits, but surgeries better by 3.4%. And then just highlighting better than a year ago as well. And then what's driving that favorability is mostly or primarily plastics and urology. At Providence, we are 7.5% better year to date on the surgeries. And so just to recall the adjustment there on the budget, we had adjusted that budgeted volume to a more reasonable level without impacting the revenue target. And then discharges favorable by just under 3% at Providence. However, the observation stays are short of budget, but pretty comparable to where they were a year ago. And then as we drop down to ACHN, primary care, short of budget, and pretty much in line with where we were a year ago. Specialty care visits favorable by 2.6%, driven mostly by plastics, ENT, cardiology, and podiatry.
So Scott, on Providence, that was the change we see as a result of an adjustment in the budget?
Yeah, well, only on the volume side. So the revenue targets weren't changed, but we had adjusted the surgery volume to effectively flexed it to what is a more reasonable target. And you can see that they're at 529 for the first couple of months compared to 369 a year ago.
So it sounds like there's a combination of adjusting the budget as well as some improvement.
Yeah.
Okay.
And there's I think we're still looking for the GI additional providers to fill that GI gap.
What about so are we looking at all three numbers was a result of an adjustment? So if we look at the average daily census, the emergency room visits, as well as the OBS days?
No, only the surgeries.
So if it's only the surgeries where we see the adjustment, that means that we have some pretty big improvement on the other three areas. I mean, like major big. Because if you recall, it was somewhere around 44%. It was pretty ugly last time we looked at it.
I think you're referring to the surgery line, correct?
Not just the surgery line, but the 12% to 15%. Those numbers are, I think, a remarkable increase or decrease, however you want to look at it, because it's a negative number from the previous reports.
Yeah, so the way I'm looking at this is if we look at not only compared to budget, but if we look at compared to prior year.
Compared to budget right now, we're what? This data is how many months?
Two.
Yeah. So we don't have trends yet.
Yeah.
I'm trying to look through the year-over-year number.
Okay.
Yeah.
Go ahead.
Make a note of that.
Yep, will do. All right, so on the next slide, operating trends of our volumes over the past 6 years have been relatively stable. The outpatient clinics in the top left-hand corner, and I guess to reemphasize that we're just 2 months into the year, but thinking back to last month, the projection for 2026, which was just based on the 1 month, was actually suggesting that we were dipping down there, and you can see that based on 2 months now, we're projecting slightly higher than a month ago. I'm sorry, projecting slightly higher than last year. Let's see. Okay, so next slide, payer mix. So as I had mentioned earlier, Medicaid showing a decrease, uncompensated up by 3.2%. So we seeing here a decrease in really across the board, Medicare, Medicaid, and commercial. And with the uncompensated being up to 25.1%. On the next slide, in January, our cash collections dipped slightly below target due to payer claim processing delays, and it's a system issue with the state HFS. However, we're expecting those issues to be resolved fairly quickly. On the next slide, denials. Our net final denials at 1.1% for January, well below the target of 2%. And then our government billing denials, which is the middle section there, continuing to trend in the right direction. And then on slide 11, we have our charitable and public program expenditures. So slight change in what we're projecting at this point for charity care and uncompensated based on what we saw in January. So we're at last month, we're in the ballpark of the 690 million. So now projecting 715. And then on the next slide, our savings initiatives. On the revenue cycle side, with the CDM pricing review that we do annually, the revenue recovery, and then the point of service collections, So on target with the exception of the top item there, but, you know, comfortable that we'll be in good shape by the end of the year. For county care, the fiscal resilience project, so the goal of taking approximately 100 million of either expense or on the expense side or the revenue side, but 100 million of benefits to the health plan over the year. We're at about 18 million, which is a projection for the first quarter, not necessarily through the first 2 months, but it's what we expect through the first quarter, and that's a combination of some progress made on the risk adjustment in the NICU, some rewards adjustments, and then some changes to some of the contracts within the plan. And then the vendor contract negotiations, which is the 40 million of agency savings for the fiscal year. It's just really too early to tell at this point how much of that we have locked in. I can say that at this point in the year, we are our run rate would put us in good shape to earn that 40 million. Just not, as I said, too early in the year to know how much of that is locked in, but we're in good shape at the moment. And then last but not least is our county care slide with the operating loss of 27 million against a budget of a loss of 7, so 19 million unfavorable. And again, the health plan continues to manage the medical loss ratio being higher than budgets and the increased utilization as well. So, any other questions I can answer?
Scott, I have a question, thank you. We had previously been apprised that the percentage of CCH uninsured patients had risen from 13 to 22% since the new administration took over in Washington. Looking at the payer mix, are we now to read the chart as suggesting that percentage is 25.1%, or am I looking in the wrong area?
No, that would be correct. As of this point in time, yes.
Thank you.
You're welcome.
Any other questions?
On that same page, Scott, if we look in the commentary section where it shows the commercial is a 2.2% decrease, and that's from the prior month. So we know that the previous months were, if we put those numbers, this number will grow because it's additive, correct?
So yeah, this is an average of the first 2 months of the year. So the last month was a bit of a blip, or flash in the pan, so to speak, on the commercial side.
Okay, so the real question I want to ask, because commercial, that's real money. Do we have any clue as to why we're losing those folks?
Again, I think that that's not necessarily a trend, right? So I don't know that we're losing anybody yet. That you would have to look at that on a year-over-year basis.
Right. Yeah.
That number wouldn't show it. So we should get the year-over-year number if that's what your question is about. That's not what this would be.
That's not quite my question, actually. Because if I understand this correctly, this is supposed to show we lost that much. For commercial, we lost 2.2% of what we had from the previous month to that month. So we reduced it that much, right?
If we do like a trailing 12 months or a trailing 6 months, that rate is likely to be unchanged. But when we start looking at smaller periods of information, that's when you really see the blips, and it's kind of all over the place.
I understand what you're saying. So it's not exactly what it says. It is oscillating.
Yeah.
Okay. I
Yes.
understand that.
Yeah, you can't really look at it. Here's January. Here's December. Here's January, because those are unique months with you have different patient volumes driven by the holidays, things like that, that doesn't show a trend.
Okay.
All right, any other questions? Hearing none. The agency reduction report, since we've only had 2 weeks, the report's going to be briefer than it usually is, so Craig and Wynn. Just kidding. We're not doing the report. I was about to say how we're not doing it because we're going to push because we just did it. And as soon as I just said agency reduction report, you should have seen Wynn's face like, oh shit. So we're going to push that until the April meeting. So the agenda is exhausted. We're adjourned.